Shah is going to cover a little bit of CMR in the non-infiltrative cardiomyopathies. So how do we classify, how do we define cardiomyopathies? It's all over the place. You can choose which type of classification you like best. This is thinking in terms of structural and functional abnormality. So in the structural side, you have the fibrosis, the scars, the inflammation, the infiltrations. In the functional side, you have ischemia, cardiotoxic agents, tachycardia-induced cardiomyopathy, pressure volume overloads in valvular diseases. And then in the genetics, you have all the different types of mutations that can produce structural and functional changes. Now, when you think in terms of specific diseases, of course, in the structural, you have the infarctions, the myocarditis, vasculitis, sarcoid, infiltrative diseases. In the functionals, in addition to what we mentioned, you have the ischemia, and then the role of hypertension, aortic stenosis, and so on that we're not going to cover because they are mostly of another type of etiology, and we already have discussed them in other sessions in this one-year course. And then the genetic mutations that can affect a bunch of different cardiomyopathies. These are the four most common that we can see. You can also be thinking just in terms of the phenotype in the ventricle. So is it dilated? It's a big heart. Is it a hypertrophic heart? Does it have restrictive features, or a few others that don't fit into any one of these categories? So echo has been the main stem of initiating a diagnosis of cardiomyopathies. Nowadays, it may not be the final word because now we have other techniques that can help us pinpoint more etiologies and whatnot, but echo continues to be the starter. Patients present in different ways, abnormal EKG, symptoms, family history. And then echo helps us establish the fact that there is some type of cardiomyopathy, dilated, restrictive, hypertrophic, or other. Give us some clue on the etiology, although this is an area that other imaging modalities can be more helpful. And then, of course, assess the severity, the impact of the disease in volumes, LV mass, ejection fraction, hemodynamics by Doppler. And often, because of all these hemodynamic changes, we can say something about how advanced the disease is, potential prognosis. So the first take-home message is, you see one, you see them all. So dilated cardiomyopathies, in general, they all tend to look alike. It's a big heart that doesn't contract well. Ejection fraction is often reduced, most of the time at least less than 50. Often like this, which is fairly reduced. You may have regional wall motion changes. It's not imperative that you don't have regional wall motion changes. And the truth is that they all look very similar. And with a picture like the one you're seeing here, the patient could have idiopathic, post-viral, alcoholic, familial, postpartum, and even ischemic. Infections, for example, acutely, you can get decompensation and the heart can't look like this, usually not that dilated. So if you have like uremia or sepsis producing transient heart failure, the heart can drop the EF, but they don't usually dilate to huge levels. This is a young woman with a postpartum. Why do we know it's postpartum? Because of the history. Again, otherwise, you see a heart that is enlarged and doesn't contract well. Now, the non-compaction type is a little bit different because it does have specific phenotypic changes in the ventricle that helps us often make a diagnosis. And what you see is these very deep recesses. Ejection fraction may vary from very depressed to mildly depressed. Interesting, it was thought to be a disease of young people, but we're not uncommonly seeing older folks that have it. So the lifespan can be very variable because they can present a lot further advanced in age. It consists of an extensive spongy transformation of the myocardium, which kind of resembles the fetal myocardium. Coarse trabeculation, deep recesses, And the criteria that had been established is that basically when you look at these recesses here, in this diagrammatic function, basically you have these recesses be more than the actual thickness of the wall by a criteria that I show you here, more than 45%. Tend to be more in the apical segments in general. That's why for the sonographers, a good short axis view towards the apex can give you very, very specific findings and actually very beautiful. They look pretty cool. That's what we see here in this particular view. You see all these recesses coming in. So, when you see a patient that you're concerned when you see the apical views, go back and get some good low apical short axis. That can be very diagnostic in these cases. I'm going to spend a little time talking about hypertrophy because I look at the entire program for the whole year, and this is the only time that myself and Dr. Shah will have to talk a little bit about that. A disease that we all know very well since we are one of the centers of referral for HCM, and we have both Dr. Naga and Dr. Bergler as our local experts and national experts. So the most common, of course, is asymmetric HCM with LVOT obstruction, where you see the thickening of the septum more at the base, hyperdynamic heart often, and then the systolic anterior movement of the mitral valve with the dynamic obstruction, in this case being quite significant. This slide reminds us that the dynamic obstruction is called dynamic for a very good reason. It may be present, it may not be present, you may have to induce it. So this is somebody that basically does not have it at rest, but immediately following exercise, you can see that it's there with. And you can provoke it with a PVC sometimes, post-PVC. You can provoke it with Valsalva. Our sonographers have become really good at doing Valsalva and then looking for SAM and LVOT obstruction. And you can provoke it with drugs like dobutamine. At one time we used dobutamine. We sort of moved away from it because there's some issues with specificity. So in general, we prefer to do simple things like post-PVC, Valsalva, and then an exercise test. The other thing that this slide shows very nicely is that the degree of SAM and LVOT obstruction has no relation whatsoever with the severity of LVH. So you may have somebody with profound LVH and no SAM. You may have someone like this one who really has, some increase in thickness. Nobody argues that there is not a basal hypertrophy here, but it's not dramatic. And if you did an LV mass by CMR in this patient, it would not be dramatically increased. So there is no relation between the obstruction and the severity of LVH. And the other thing is that very good studies done in Boston by Bob Levine and his group showed very nicely that SAM was more related to the contraction pattern of the heart and abnormalities of the mitral valve. The posterior leaflet is often a little longer. The insertion of the pap muscles can be a little bit more anterior. So there are some fine changes in the mitral valve that makes that patient under a condition of hyperdynamicity develop the SAM. And it's independent of the left ventricular hypertrophy. Very important because we forget about this. Not everything that looks like HCM is HCM. In fact, we had that case yesterday that was very interesting because the patient also had hypertension. So often you see hypertensives that kind of look like that. We occasionally see very elderly people, women particularly in their 80s. I had a wonderful case a couple of years ago, 85 years old. Severe SAM, severe obstruction, almost a suicidal heart. She was in pulmonary edema, sick like a dog. And actually, she was fixed with a clip because her septum was not thick enough to go after ablation, and her MR was severe, and we clipped her, and it was like 2 weeks later, she was out of the hospital, and a month later, she was shopping. I mean, it was one of those amazing cases. Now, she was 80-something. How would her echo have looked when she was 60? So certainly, there are patients that present later in life. Do they have the genetic version with a little bit of with a very slow penetrance? And, they often have had hypertension for a while. So it's an interesting story. But don't forget that, at least in the literature, the athlete heart has been always put in as a possible differential because they can have a fair amount of what looks like hypertrophy. Key thing there is that, yes, they are thicker than normal, but they have absolutely normal diastolic function, normal relaxation, and nowadays normal strain. Amyloidosis at times can look like it, and a sigmoid septum of the elderly. Those are the common things. However, look at this case here. Is that HCM? It looks like HCM, right? No SAM, but it looks like HCM. Could that be a phony amyloid? Yeah, we had that case yesterday that looked like it and ended up having findings of amyloid. But what this one is a Fabry's disease. It's one of the few cases I could find in our interesting case. That was a documented Fabry's disease. An X-linked recessive metabolic defect. And the important thing of making this diagnosis is that nowadays there is treatment for it. So there is a whole host of weird things that we don't always think about, and they can have a phenotype looking like HCM. This is, most of the time we can figure this one out, and of course, these two we can figure them out, if not by echo, by CMR. But these other ones are good to keep in mind that, not everything that looks like HCM is going to be HCM. Now, asymmetric is 90%. Occasionally we do see concentric, with or without SAM. And then we have the apical variant, which, they say 3%, but actually, I don't know if maybe it's getting up, because we're seeing, every year we see some cases. I mean, I follow several patients with it. This is the most rare of all, the mid-ventricular. And then asymmetric free wall hypertrophy is also very, very rare. So this is your typical hypertrophic cardiomyopathy, and this is your apical HCM. The important thing about this condition, two things, as some of you do know, they have this very, very diagnostic EKG with deep T-wave changes. I always say that a patient with that EKG can buy themselves a night in any hospital they want to. So if you're homeless and you have that EKG, just show into an ER, say you have chest pain, and you'll be in. Because it's a very, very abnormal EKG with very ischemic looking T-wave changes. Case like this, diagnosis is very easy. The angiogram shows this apical trapping because there is this obstruction, and the pressure in the apex can be extremely high at times, particularly during exercise. They can have apical infarcts. This is now can be picked up very nicely by CMR, and the more scarring apical infarct they may have may trigger arrhythmias, and there is some element of sudden cardiac death in some of these people. For us in echo, the important thing to remember is that this can be missed. In fact, if you don't think about it, you could easily miss it. This is your EKG, very typical. Of course, this could also be good old CAD with ischemia, but you see somebody with increased QRS voltage and this type of EKG pattern, always think of apical HCM. Color Doppler can be very, very helpful because you see with color very nicely that apical trapping here can help you see the cavity better. And of course, contrast is 100% diagnostic, okay? For the sonographers, the short axis view at the apex, also very helpful. And the reason why this is all important is that because of all this muscle here, if the patient has a little bit of difficult window to get through in the apical views, which is not uncommon in Texas, and on top of that, you have all that muscle at the apex, you can have a lot of attenuation, and the regular 2D echo image may not show you the apical hypertrophy. However, a good short axis at the apex, most of the time, will show it. So sonographers, again, when you do your short axis, try to get down to the apex almost routinely. You pick that, and you cannot see it well here, grab your contrast bottle and put some contrast. Because in honesty, Other than looking for scar, which in fact you can see a little bit, I don't know if you all can see that there is a tiny amount of dyskinesis or akinesis right there at the tip of the apex. Other than looking for scar, CMR should not be needed for a diagnosis. If you do, your job and your suspicion and you do your contrast, literally close to 100%, we should be able to diagnose it in the echo lab and then use CMR appropriately for the other things that you're going to hear sooner in a little while. Now, this is another condition that we see quite often here, right? 60-year-old lady. She was in a very stressful confrontation, came in with chest pain, and looked like an LAD infarct, normal coronaries, and 10 days later, she's recovering very nicely. So this is the apical ballooning, Takotsubo, stress-induced cardiomyopathy. Those are all terms that have been used. This is the most common, but not the only version. Here, I think I'm showing you, here's one where the abnormalities are more in the mid-segments. The apex is contracting, but you have these mid-segments that are not contracting well. Again, nice recovery. Most of the time, they have full recovery, but not 100% of the time. So some patients can linger in with some residual abnormalities, and those tend to have also a little bit more complicated long-term course. Current thought is that it is a catecholamine-induced cardiomyopathy. Sometimes we see it also after hemorrhagic strokes. There is some sort of release of catecholamine so sudden and so significant that it creates abnormalities in the myocardium. And endocardial biopsies have shown changes in the myocardium with mononuclear infiltrates, contraction band necrosis, and so on. And the most interesting thing is that now they have an animal model. So they have reproduced the disease in animals by subjecting the poor animal to a lot of stress. So there is, and then what they have done is they have pre-treated the animal with beta blockers and have had a lot of trouble inducing it. So, and it makes sense, right? If you're taking beta blockers for hypertension or something, then you might be less likely to develop the disease when you're confronted in a high stressful situation. Arrhythmogenic RV Dysplasia is a tough one for us. It's one that requires a lot of thinking through it. Clinically, of course, they present frequently with arrhythmias and a family history of sudden cardiac death. And what we look in the echo most of the time is abnormalities in the right ventricle, i.e. either aneurysms, segmental wall motion abnormalities, or RV dilation. So these are some of the criteria that have been put out: a reduction in the fractional area shortening of the RV in the apical fourth chamber, localized aneurysm, segmental dilation, exclude other causes of RV involvement, usually normal LV, although rare cases have been reported. And of course, you're going to hear more about that with the MRI because it has been very helpful. I'm going to touch on the infiltrative restrictive, mostly because it's the only time that I'll be able to talk about echo, because on phase 2, it'll be mostly CMR and PET. And this is a limited list of the most common restrictive infiltrative diseases. Amyloid, it looks like we have an epidemic now. We have become so tuned about thinking about amyloid that now we're picking it up a lot more in the old days. Even aortic stenosis patients, we're showing that some of them may have, up to 20% of them may have amyloid. And this is your classic that we all know about. The small cavity, increased wall thickness that looks like concentric LVH. Frequently, they have also biatrial enlargement. EF could be all over the place, normal, even hyperdynamic, or abnormal, depending on the severity of the disease. They always have diastolic dysfunction, at the very least, grade 1. Increased myocardial speckle appearance is really not that helpful. It's probably the weakest of all the criteria. And then doing a relative comparison of the increased thickness of the echo with the QRS voltage have created some clues, but again, you will not put all your eggs in that basket. And it's only because we have become so much more suspicious of the disease nowadays that we're picking it a lot more by all the other tools that you will hear about later. And also now we have treatments. So because we have treatments, likewise, it's important that as clinical cardiologists, we keep a good watch for them and take a good history about carpal tunnel syndromes, spinal stenosis, all the great things that you heard yesterday in our case of the month presentation. Before I do this, I think it's nice that you can see this here. Even with no speckle tracking, one feature that you would nicely see is that look at that apex contracting compared to here. So this apical sparing looks very nice on the speckle tracking, but most of the time, if you have a careful eye, you will pick up that this is shortening much, much dynamic than these regions here. Then, of course, the strain comes in and shows very nicely this area towards the apex that has a lot higher values. This will be these values down here. And the bullseye then shows that very nice so-called apical sparing. Suspicious, raises that light for you to think about it and do more testing, not necessarily 100% specific, okay? Can be seen with other things, including, for example, renal failure, hypertrophy with renal failure and so on. But when you see this in the company of the other things, that should always raise your thinking through and proceed with further evaluation, as you will hear more. So what's the diagnosis? LV is not dilated, but the EF is down, okay? Left atrium, a little bit enlarged. EF, 40-something, okay? Now, do any of you see something here that makes you now more concerned? And if I tell you that this patient has had some chronic pulmonary issues, then you would be more concerned of long PR interval, right? So what disease would be thinking of? Sarcoid, right? So again, but there's nothing in that echo that comes down with the word sarcoid. You know, it's putting the echo with the consideration of a clinical presentation and so on. So there has been a lot of stuff written about ways to suspect sarcoid, which of course nowadays can be extremely helped by CMR. But from the clinical side, basically, if you have a patient in the right setup, some pulmonary disease and whatnot, and now they have EKGs that have either right bundles, left axis deviation, AV blocks, a lot of VT, premature ventricular contraction, abnormal Q or STT changes. I mean, you can see that this is a whole gamma of non-specific findings, but you put them in the context and then you start thinking about it. With the echo, you look for abnormal one motion. These people can have regional abnormalities without coronary disease. The case I showed you didn't have it, but you can see regional one motion abnormalities, okay? They can have perfusion defects, and of course, they can have abnormal hemodynamics. CMR, obviously, is making our life a lot easier these days. What about this one? Sick heart, right? All four chambers are sick. There's no part of the heart here that looks good. Okay. But, I mean, this could be anything, right? Again, notice that the heart is not extremely dilated. I mean, this is the scale. So here we're talking about probably 5+, not even 6 or 7. And here it doesn't even look that dilated. Okay? So could be a lot of things, right? This is a nice example before we go to diagnosis. How bad is that TR? 5+, right? Yet we see nothing, right? It just shows that, when basically you have no orifice, you have just basically a big orifice and blood goes back and forth, you can see the spectral here. It's torrential TR, right? It just shows you, again, some of the issues that we have with color once you get to that level of low velocity flow going back and forth the tricuspid valve. All right, so we go back to very high serum ferritin. So now, of course, now you know. And in fact, I think that, obviously CMR can be extremely, extremely helpful. But once again, this is a disease that have no distinct echo features, okay? And it's my bias that anytime we see a patient presenting with new heart failure and reduced EF, it's so easy to do. I put a ferritin always as part of my workup, costs nothing. Well, it costs a little bit, but it's very minor. Certainly costs less than a CMR, okay? And you'll hear more about CMR's contribution in the next session, session 2. So that's my own bias. And the reason for these things is that, of course, this is a slide that you will see again probably next week when Dipan talks about restrictive cardiomyopathies, is that many of these restrictive cardiomyopathies, if you do nothing about them, they have even a worse outcome than the dilated non-ischemic cardiomyopathy, which nowadays we have so many good things that we can give them to make them better. And with amyloid now having ways to treat, this one probably is the most important one that we need to have in our radar screen, not to miss. I think sarcoid would be another one. This one, if we do a fair thing in almost everybody, that shows we should at least have something to help us move forward to the next level. The problem with hemochromatosis is, and I think you'll hear from Dipan next week more on that, if you pick it up this late, it's possible that no matter how much iron you try to get out of the body, it may be hard to revert. So the trick here is to have patients that already have family history or whatever of hemochromatosis and catch them early. And I think you will hear more about that next week. So early detection is very important for many of these diseases. And I'm going to finish with this one. This one looks like a hypertrophic cardiomyopathy, right? Or apical. But notice that the appearance of this material here is just a little different to the rest of the myocardium, okay? Patient has a lot of heart failure and very high eosinophil. So this is a very nice example of Loeffler's, or endomyocardial fibroblastosis. Very interesting condition, rare. This was a slide that Susan Wigger was kind enough to give me some years back. There are the two versions, the tropical, which is infectious from schistosomiasis, and the one that we tend to see more here, the non-tropical. Still very, very rare. It's caused by abnormal cells that are toxic to the, all these eosinophilic cells are toxic to the myocardium. They cause basically infiltration with the stuff that looks like a clot, in essence. The heart becomes very restrictive. They can have a lot of MR, diastolic dysfunction. So I'm going to pass it off to our distinguished director of the Imaging Center, Dr. Shah. And Dipan tells me he's going to cover pretty much the role of CMR in all the ones except the infiltrative, since that will be part of session 2. All right, so if I can disconnect here.
Faisal?
And get you connected.
Dr. Nabi has a question. Can we get a microphone?
Hold on.
Yeah, do we have a microphone?
Bring a mic, please. Someone, mic. For the benefit of our webcast viewers, I will repeat the question. Go ahead. Faisal, I'll repeat the question.
I've seen one or two echoes where it looks like a completely normal heart, and for some reason the sonographer has gotten the patient with a salva, and all of a sudden you see outflow tract obstruction or SAM. So I just wanted to ask you, is that possible in a normal heart, or is this always engineered in a pathology?
So the question is, can you see SAM and LVOT obstruction in an otherwise normal heart? Okay, there's one condition that is not HCM, in which you can see SAM and severe LVOT obstruction, and it's crucial that we make the diagnosis. We all see at least one case a year, and that is an acute MI, comes in, hyperdynamic LV, severe SAM and obstruction. But maybe even that patient that came in with the acute MI, maybe before the MI, if one had looked at them in detail, maybe they would have had some mitral valve abnormalities, something in that mitral valve that made it then develop the SAM with the hyperdynamic condition. And you have those, the base is almost obliterating, but then you have this big infarct due to the LAD infarction.
A normal
That's
heart
one,
should
but
not.
I'm not sure that I know any other condition that you could have just a normal heart with SAM.
A completely normal heart should not.
It should not, I don't think so. Yeah.
I mean, you may have some hypertrophy that would a concentric remodeling that could. And remember, it's the position of the mitral valve in relation to a dynamic situation. You can have it in Takotsubo at times, because of the same thing as Miguel
Yeah.
was mentioning, right? You've seen that.
Okay, very good. Thank you for that very nice overview of the echo in cardiomyopathies. And so let me turn now to how CMR can help. And what we've done this year, we've switched it up a little bit so that we're really trying to hit on nuclear and PET techniques as well. So really to have an idea of how all of these imaging modalities can help in the setting of patients with cardiomyopathy and heart failure. Obviously, one of the key things that we want to know is ejection fraction. And so, that has important implications from both a management standpoint as well as a prognostic standpoint. We know that most of the time what we're dealing with is heart failure with reduced ejection fraction, where the EF is less than 40%. And this is where most of the therapies that we've had up till this point have been developed for. Although now, there's more and more therapies for specific subtypes of patients with heart failure with preserved ejection fraction. And what we'll talk about is how we can use imaging to try to help give us clues into some of these other alternative pathophysiologies. So the other important thing I think when we deal with heart failure and cardiomyopathies is we want to know, is this due to ischemic disease or non-ischemic disease? And the traditional way that we do that is by coronary angiography, which is very good at identifying the patient on the left-hand side here who has a high-grade coronary obstructive lesion, or the patient on the right-hand side who has no coronary disease. And we know that this distinction is important from a prognosis standpoint. Patients with non-ischemic in general do better than patients with ischemic cardiomyopathy. And also from a management standpoint, you're going to treat these patients differently as well. So can CMR help us just in identifying ischemic versus non-ischemic in somebody that, for whatever reason, doesn't go on to get a heart catheterization? Well, in fact, I think it's the ability to directly visualize myocardial infarction and scar, as we talked about in one of the earlier sessions, I think can actually be utilized to help us identify, in fact, patients that are likely to have dysfunction that's due to ischemic heart disease versus those that have non-ischemic heart disease. The classic finding in ischemic heart disease is that you get hyperenhancement that occurs, one, within a coronary artery territory distribution, and two, tends to be subendocardial or transmural in nature, as is shown in these two examples here. And simply looking at wall motion is actually not very good at distinguishing ischemic from non-ischemic. And if I showed you these two examples here, and I told you that one of these is an ischemic cardiomyopathy and the other is a non-ischemic, I think based on wall motion, it will be hard to identify which is which. Now, if we incorporate our delayed enhancement MRI findings, I think it becomes much easier. On the left-hand side is a patient who has evidence of LGE all along the septum and the apex. On the right-hand side is a patient with no hyperenhancement at all. And in fact, by cath, the left-hand side patient had coronary disease, and the one on the right-hand side had no CAD. Another example case where there's more regional dysfunction. In this case, both of these hearts are larger than the last two examples that I showed you. And again, just looking for regional dysfunction doesn't help with identifying ischemic or non-ischemic. But if we look at the delayed enhancement MRI, you can see on the right-hand side, this patient has transmural hyperenhancement, which corresponds to the LED distribution. The patient on the left-hand side has no evidence of hyperenhancement at all. And in fact, by cath, the patient on the right had included LED. The patient on the left had no coronary disease. So there's several studies that have looked at this and found, in fact, that almost always in the setting of ischemic heart disease that's chronic in nature, you're going to have LGE. So it's very rare to have ischemic cardiomyopathy without having at least some evidence of myocardial infarction occur. Obviously, we talked already about the fact that in ischemic patients, we use this information to help predict likelihood of functional improvement. But what about in the non-ischemic patients? So the first thing is identifying a pattern of myocardial injury that's not ischemic in origin. So it goes back again to this wavefront phenomenon, which we know that ischemic injury starts in the subendocardium, progresses outward. So if you see a pattern of enhancement that is shown in this left-hand side image where it's in the middle of the myocardium, another pattern of hyperenhancement where it affects the epicardium but spares the endocardium, or you see one that's very diffuse and doesn't really fit with the coronary perfusion territory. These are all clues that the hyperenhancement pattern that we're seeing is in fact a non-ischemic pattern of injury. And again, why is this important? Because the underlying etiology of the non-ischemic cardiomyopathy has important prognostic implications. And so what our goal really is going to be is to try to look at this kind of series of different non-ischemic cardiomyopathies that exist. And what I've done is I've tried to classify them, and there's many different ways you can do this, but I've broken it down into those that we think of that have a genetic predilection, and these would be things like HOCM, ARVC, LV non-compaction, maybe there's some question mark about that. Those that are what we call the dilated cardiomyopathy, most of the time that's the idiopathic. Sometimes it can be viral myocarditis or Takotsubo's. And then also those that are inflammatory, which are things like sarcoid, SLE, connective tissue disorders, and then things that are infiltrative or restrictive, like amyloid, iron overload, Anderson-Fabry disease, and a variety of others. And although there's overlap, I think the idea is that if we kind of think of it in this framework, and let's start approaching these cardiomyopathies one by one, and try to see what are the CMR features that you would see. So what we're going to do for today's lecture is focus on the two left-hand side, and then next week we're going to talk about inflammatory and the restrictive, and at that time we're also going to have a complementary lecture about the role of nuclear-based techniques as well. So first thing is, what are the tools that we have to utilize when we're assessing cardiomyopathy patients? And the idea is that you want to try to use every tool you have in your armamentarium because, in fact, there can be overlap, and identifying the etiology is not always straightforward. So the first thing, obviously, is just volumes and ejection fraction to get an idea. Is this a dilated heart versus is this a small cavity, more of a restrictive type cardiomyopathic process? And this is where you want to look at LV and RV volumes, LV and RV ejection fraction, but also look at LV mass, because differing cardiomyopathies can have differences as far as what effect they have on left ventricular mass. The other tool we've already touched on is the use of this late gadolinium enhancement technique. Now, one thing I want to make sure that we go over, oftentimes we refer to it as SCAR, but the reality is the correct definition is probably refer to it as hyperenhancement or late gadolinium enhancement. And the reason for it is the underlying kinetics here by which you see hyperenhancement isn't necessarily due to the presence of myocardial scar. Obviously, we see this in acute infarct where there's no scar present at that point, but it's due to an expansion of the extracellular space. So there's an increase in extracellular space relative to the amount of myocardium or myocardial space. That can occur obviously in chronic infarcts where there's scar. It can occur in non-ischemic cardiomyopathies where there's scar deposition, but you can also see this in conditions such as infiltrative cardiomyopathies where there's protein deposition within the cells or outside of the cells, between cells. That will also lead to an expansion of the extracellular space, and as a result, evidence of late gadolinium enhancement. The other technique that we have, and I think the next two I'm going to touch on are more emerging techniques, and these are the T1 mapping and the extracellular volume fraction. And again, the full role of these techniques, I think, is still being established. But the unique advantage, I think, of these newer T1 mapping techniques is that they don't require regionality in gadolinium uptake. So whereas our delayed enhancement MRI, the basic principle behind it is we find an area of normal myocardium and make that black, and then see if there's any areas that have more gadolinium uptake than an area of normal myocardium. Whereas these newer mapping techniques actually try to identify what is the native T1 time of the myocardium and what is the volume of extracellular space as a percentage of the total myocardial volume. So, and then this is a nice little kind of concept diagram that was put forward by Martin Ugander several years ago. And the idea is that if we incorporate this information about native T1 values and ECV, it may actually be an adjunct in addition to our standard assessment of EF, mass, and late gadolinium enhancement to try to help in identifying potential differential diagnoses for different cardiomyopathies. And the basic principles, I think, here is this. There's two things that we know that will lead to shortening of myocardial T1 values. and that's fat. And again, that's why when we do a T1 weighted image, fat appears bright. And there's also iron. Now, the mechanism by which these two cause T1 shortening is different. Iron causes it more by causing inhomogeneity, whereas fat causes it by increasing the relaxation of the protons. But the basic principle, I think, is when you see an area of high signal on your delayed enhancement image, you can't necessarily know if that's hyper-enhancement due to scar, expanded extracellular space, or if it's fat. But using this native T1 techniques can actually easily differentiate between the two. And then obviously for iron, we'll touch on next week, we have more sophisticated techniques than just T1 mapping. But again, when you're trying to kind of put together a differential diagnosis, you want to use all the pieces of data that you have. So let's now move on to specific cases. So let's talk about some examples of genetic cardiomyopathy. So here's one here where I think the diagnosis would typically be straightforward from a morphologic standpoint. It looks like there's increased wall thickness in the apex. And you can see it almost looks like during systole there's obliteration of the apical region, and overall LV function is quite preserved or normal. And then when you add to this the delayed enhancement MRI, what you see in fact is high signal or hyper enhancement in this apical cap, suggesting that there is actually myocardial scar or infarction that's occurred from these apical trapping. The more kind of garden variety hypertrophic cardiomyopathy that we tend to see is associated with the septal hypertrophy, as we see in this example patient here, where the thickness of the septum is almost 2.5 centimeters, whereas your lateral wall thickness is about 7 or 8 millimeters. And when you do the delayed enhancement MRI in these patients, you see patterns of hyperenhancement that you would not expect to be due to coronary disease, because you've got at the anterior RV insertion site and the inferior RV insertion site, you've got an area of hyperenhancement that's really kind of mid-myocardial in nature. Again, not what you would expect to see with coronary disease, plus you've got a lot of other patchy enhancement in the septum, as well as a little bit in the lateral wall. So when you see that coupled with the hypertrophy, the increased wall thickness, that raises your suspicion of hypertrophic cardiomyopathy. Now, there's data in a multi-center observational study showing, in fact, that the amount of hyperenhancement, or in the setting of hypertrophic cardiomyopathy, what's really due to scar, is associated with risk of adverse cardiovascular events in this patient population. And in fact, what they found was that patients with more than 15% hyperenhancement tended to have a much worse prognosis. And this was true, interestingly, for sudden cardiac death, but also for heart failure, end-stage HOCM-related death as well. So really, the hyperenhancement that you see in hypertrophic cardiomyopathy is really a marker of the underlying disease process that's occurring in these patients. So it can help you in identifying or at least generating a differential diagnosis, which includes hypertrophic cardiomyopathy, but also the extent of it helps you in identifying the prognostic significance in these patients. So let me go on to one thing that you probably do not want to use CMR for, and that's in these HOCM patients trying to identify dynamic LVOT obstruction. And the reason for it, or not, I shouldn't say identify, but rather quantify. And the reason for it is if I show you this Doppler image here, you can see it's a dagger-shaped jet, which means that the duration where the peak velocity is actually a very short period of time. Now, these echo images are very high temporal resolution images, about 3 to 5 milliseconds. Our typical phase contrast CMR images are about 40 to 50 milliseconds. And so this is, I think, a pitfall you don't want to fall into, which is if you see a velocity of 2.5 on the CMR and say, okay, there's a 2.5 millimeter or meter per second jet, the reality is you could significantly underestimate a dynamic obstruction. And so that's an area where we would defer to our echo colleagues and really quantify the extent of the velocity. The other fact is also we don't have the ability to do dynamic maneuvers, Valsalva and things like that, because most of the phase contrast and most of the CMR techniques are taken over several cardiac cycles. So as a result, you also want to recognize the strengths, but also the pitfalls. Let's move on to another condition, which is arrhythmogenic right ventricular cardiomyopathy. Now you notice these are, so I think there's two things that are important to keep in mind. Imaging provides you with criteria for ARVC, but doesn't necessarily make the diagnosis per se, because it involves, family history, clinical findings, EKG findings, and everything else. And you really need two major criteria to establish a diagnosis of ARVC, and imaging can provide you with one of those criteria. So by CMR, the quantitative criteria are, and again, notice both of these, the major and minor criteria, start with step one, which is you need to have wall motion abnormality. So if you have completely normal RV myocardial function, then you really can't have RV dysplasia. So you need to have regional RV akinesis, dyskinesis, or dysynchronous contraction, and then couple that with some measure of either RV dilatation or RV dysfunction. And so for major criteria, use a RV end diastolic volume index of greater than 110 for men or greater than 100 for women, and an RVEF of less than 40. So if you have wall motion abnormality plus one of these, then you've made a major criteria. For minor criteria, it's basically wall motion abnormality, but RV dilatation that's a little bit less pronounced. Really, both of these numbers are just reduced by 10 milliliters per meter square for men and women, or an RV ejection fraction that's between 40 and 45, so a little bit less dysfunction for minor criteria. Now, what about non-compaction? So here's an example of a patient who has prominent trabeculations that we see all across both the apical and mid-ventricular short axis views with deep recesses. This person had an LV end diastolic volume of 190, depressed LV function, and when we looked at the ratio of non-compacted to compacted myocardium, we get a ratio of about 2.8. Now, one of the ways that it's done in CMR is actually based on diastolic measurement, so that's a little bit different than the way it's done in systole. And the original criteria came out in 2005 in a series by Peterson and colleagues, where they found that a threshold of 2.3 identifies pretty nice, or separates pretty nicely patients with LV non-compaction versus other conditions. Now keep in mind, most of these are small studies with relatively small numbers. So there's also another criteria for LV non-compaction, which was proposed about 5 years later by Jacques and colleagues, where they actually went through and looked not just at individual segments, but looked at the global mass of non-compacted myocardium to the mass of compacted myocardium. And what they proposed was a cutoff of more than 20% of non-compacted to compacted myocardium ratio to be pretty good at separating between patients with LV non-compaction versus those with dilated cardiomyopathy, HOCM, or control. Another thing to keep in mind at LV non-compaction, and these are all things that you look for because they help you to further solidify the diagnosis. So in addition to looking for the trabeculations, looking for LV dysfunction is also that there can be blood trapping in these recesses and you can develop thrombus formation. And here's an example of a patient who's got a pretty large thrombus in the LV apex that's present within these recesses. So, and I think one of the things that I want to try to stress, LV non-compaction is really a spectrum. And, obviously there are some genetic association, but there can also be cases where you have the phenotype of LV non-compaction in a variety of non-genetic conditions, even in cases of athletic heart, sickle cell disease, renal failure. So again, I think what you're really identifying is the phenotype more than you are a specific disease process. And then I think what you're trying to look for is some of the stigmata or the sequelae that can occur, one of which is scar formation and the other of which is thrombus formation. And then this was a nice meta-analysis that just came out this month in Circ Imaging by Stefan Peterson and his group, where they looked at basically all published literature on LV non-compaction, either by echo or by CMR, where there was outcomes ascertained. And what they found in this meta-analysis was, in fact, that prognosis in these patients is more related to the ejection fraction than it is to the amount of trabeculae. So I think it's always important to keep in mind the amount of trabeculae we've seen also can be dynamic in nature. It can actually increase or decrease, but it's the ejection fraction that seems to be the main driver of prognosis in these patients. So let's move on now to the dilated cardiomyopathies. I'm going to wrap up here in the next 10 minutes or so. Obviously, Takotsubo's was already touched on. What are you looking for? You're looking for transient, reversible, regional wall motion abnormalities that are beyond a single epicardiovascular distribution. obviously the absence of flow-limiting coronary disease or an acute plaque rupture. You should see new EKG changes, and then obviously you want to exclude other causes that can mimic this, such as intracranial bleeding, pheochromocytoma, hypertrophic cardiomyopathy, and et cetera. And so this was actually a very nice multi-center study with over 200 patients that underwent CMR with a diagnosis of Takotsubo's. And what they're trying to do is to characterize what is the location and pattern of the dysfunction. And what they found was that most of the time, it's typically what we typically think about, which is the apical ballooning pattern, which occurred in about 82% of the patients in this cohort. But about 17% of the time, the apex and the base were spared, and it was the mid-ventricle that actually demonstrated the dysfunction and the ballooning pattern. And then, in a couple of cases, 1% of the time, they actually found a inverted or basal ballooning pattern. And then I think also interestingly is that about a third of the time, there was also an effect or an involvement of the right ventricle as well. And they coined this phrase, biventricular ballooning. Now, what are the findings when we do our delayed enhancement MRI? So the reality is, when you do delayed enhancement MRI, you generally don't see any hyperenhancement in these patients with Takotsubo's, and that's also consistent with the fact that they really don't have much in the way of an enzyme release in the setting of Takotsubo's cardiomyopathy. And then furthermore, I think further supporting findings of this is that when they brought patients back for follow-up in this series, the ejection fraction normalized in most of these patients. So the EF went from 47 to 66, and then the LV size, LV and diastolic, went from 134 down to 118. So really significant reverse LV remodeling that occurred. Now, here's another case here. This is a 44-year-old gentleman who comes in with presentation of chest pain. He has a history of tobacco use and a family history for premature coronary disease. His EKG on admission, he comes in on Friday night, shows some nonspecific STT changes, but no clear ST elevation. He gets treated with medical therapy, has a peak enzyme rise of troponin of 30 and an MB of 105. And then when he goes to cath Monday morning, we see this finding here, which is that the coronaries all appear to be pretty normal. So the question now becomes, what's the culprit for his cardiac enzyme release? And, I think there's several things that it could be. One of the things you want to consider also is myocarditis. And this, I think, is an area, this is a situation where CMR can be very helpful. When we do our delayed enhancement MRI findings, what you notice is that there's this pattern of high signal or hyperenhancement that's, again, in the mid-myocardium or epicardium, and you can see it very nicely on this long axis view where there's multiple patchy foci in the lateral wall. And in this setting, this is the classic finding that you would expect to see that would suggest myocarditis. This is a series from a German group almost 15 years ago where they looked at patients that presented with clinically suspected myocarditis, did an MRI on them, identified where the area of hyperenhancement was, and then actually took them to the invasive lab and did endomyocardial biopsies within the LV where they tried to focus to get a biopsy specimen at the site of the hyperenhancement. And what they found, here's an example patient here where you can see, again, epicardial to mid-myocardial hyperenhancement in the infralateral wall. And in the 32 patients that they enrolled in this protocol and did endomyocardial biopsy, they found 90% of the time there was evidence of active virus present. 2/3 of the time it was parvovirus, and about 1/4 of the time it was herpes type 6 virus. And then the biopsy was negative about 1 in 10. Furthermore, this group also reported some data which suggests that the location of involvement in viral myocarditis may be different depending upon the underlying virus. And so what they noticed is that in most of the patients with parvovirus B19, the area that showed hyperenhancement was really the lateral wall, whereas in patients with the herpes type 6 virus, it tended to show more of a septal pattern of hyperenhancement. And then lastly, when they followed these patients up, those patients that presented with suspected myocarditis but had no evidence of LGE on CMR had a very good prognosis, as is shown in the red line, whereas those who had any evidence of LGE showed a worse prognosis, with regard to all-cause mortality, sudden cardiac death, as well as cardiovascular death. And then the last condition I want to touch on for this week is the idiopathic dilated cardiomyopathy. Now again, this is to some extent kind of a wastebasket term where we don't find any other underlying cause. What's the pattern of enhancement that you see? So oftentimes these patients with advanced idiopathic cardiomyopathy will have an area of septal hyperenhancement that tends to be mid-myocardial, but they can have other areas as well. But again, the clue to this, the key to this is that you want to see a non-coronary pattern, because we know that even in patients that are thought to have non-ischemic cardiomyopathy, by autopsy studies, about 10 to 15% of them will have evidence of myocardial infarction. So what you're looking for here is evidence of non-coronary patterns of enhancement. And then this was some data from the group in England where they followed a series of close to 500 patients, and they found that those patients with non-ischemic dilated cardiomyopathy who had evidence of hyperenhancement had a worse prognosis than those patients who did not have any evidence of hyperenhancement by CMR. And again, this held true for all-cause mortality as well as for cardiovascular mortality or need for heart transplantation. And it also held true for sudden cardiac death risk as well. So, and then this is just a meta-analysis looking at multiple studies which all show consistency generally of the findings, which is that in the setting of non-ischemic cardiomyopathy, having LGE is associated with a worse outcome. So let me stop here and just kind of wrap up what we've touched on so far. And again, we'll come back to this cartoon next week as well, but the idea being with this ability to directly visualize myocardial damage, we can actually characterize not only the presence, but also the location and the pattern. Whoops. And the left two examples where it's subendocardial or transmural, you typically think of coronary disease as a cause of the hyperenhancement. On the right-hand side are some of the differing patterns of enhancement that you can get with some of the differing conditions. And notice there's overlap. And so I don't know that the pattern of hyperenhancement in and of itself is going to make a diagnosis of a specific cardiomyopathy, but I think it can help you to generate a differential diagnosis and include that with the other pieces of data, such as look for adenopathy within the chest, look for wall thickness, look for T1 mapping measures, which may be useful, to really try to help further narrow down from non-ischemic to the underlying etiology, or at least a few different etiologies in your differential. So to wrap up, I think where CMR, the starting point I think is really in differentiating HFpEF from HFrEF, in identifying ischemic versus non-ischemic, and then really it's the presence and pattern and extent of fibrosis which seems to aid both in refining your differential diagnosis, but also in giving you prognostic implications. Thank you for your attention. Okay. Dr. Q, you want to come up? Any questions from the audience?
I have one comment. Just to put this together with our previous chronic hibernation talk, be careful. If you don't have LGE, you don't exclude yet an ischemic cardiomyopathy. Actually, that's a beautiful positive marker for you to do something. So although it's rare not to have LGE uptake in an ischemic pattern, if you don't have any and have severe ischemic heart disease, this is your best scenario for recovery. So you have to combine always what coronary anatomy is, in addition to all what you just saw today.
Yeah, and I think that the data I was showing was in the setting of chronic LV dysfunction, so more than 3 months. If LV dysfunction more than 3 months, and that's what I'm saying, that's different than a patient who acutely presents with LV dysfunction. Absolutely. Right. Yeah, so
the typical amazing hibernation is no LGE, bad dysfunction, severe triple vessel disease or left main disease.
But I'll tell you, to have chronic LV dysfunction, we've not seen it. We've not seen no hyperenhancement at all. You may have very little, but to have no hyperenhancement at all, multiple studies have shown this, and our experience also shows this.
You have to involve assessment of the coronaries, be it with CT or invasive, for you to be able to make an appropriate management decision on these patients.
agrees completely. But comment and question. So the comment is, in the non-ischemic cardiomyopathy, the absence of LGE is a good prognostic finding.
Yes.
Right? The opposite, okay.
Correct.
It's interesting, by echo, there's now a lot of papers showing, not a lot, but there's clearly papers with large sample sizes showing that strain will do the same. So you have a guy with a body F, but if the strain is staying over 11 or 12, they have much better prognosis than if the strain is 7 or 8 for the same amount of EF, which is an interesting, partner of this finding. Then the other thing is, years ago, it was shown that if you have a non-ischemic cardiomyopathy and you give them dobutamine and they have contractile reserve, likewise, they do much better over time. So the point is that there are multiple ways of looking at this with a similar conceptual type of finding. My question is the following. Myocarditis. Guy comes in, bad myocarditis, you treat them, they get better, okay? You already showed that if they don't have LGE, they do better. But what about if they do have LGE? Is there any studies showing that if you relook at them 6 months later and the patterns have regressed, that their prognosis change? Is there anything on the long-term follow-up of these people?
Yeah.
Because one of the issues we have with this patient is, do we keep them in heart failure management for the rest of their life, even though they have now an EF of 60%?
Yeah.
Or can we use CMR to help us guide who needs to stay and who could come out of medications?
Yeah, no, that's a very good question. So I think two things. There have been studies that have looked at repeat imaging to say, what do you see on repeat imaging? There haven't been any studies that have correlated changes between scan 1 and scan 2 and prognosis, right? Because again, you need much larger sample size for that. So yeah, so the studies that have shown that most of the time when you have myocarditis that's resolving, the hyperenhancement in the acute setting is always going to be larger than what it is in the chronic setting once all of the edema goes away and the that area gets fully replaced with replacement scar. So what you generally see is that the size of the hyperenhanced region gets a little bit smaller than what it was initially. Now in some cases, if the size of the hyperenhancement was so small to begin with, as it shrinks, it may get below the resolution of your technique, so it looks like it's resolved. But the reality is all it is doing is just a change in the size. Now from a management standpoint, that's a good question. I don't think anybody knows the answer to this. The one thing I'm always kind of left with is that these people have some underlying damage to their myocardium. They've had myocytes that have been destroyed, and they've got some collagen scar that's there. Now, again, the amount may be small, but how do you, at what point do you say, okay, now can I withdraw therapy? That's a tough one. And I mean, in a clinical practice standpoint, if they're tolerating it, I tend to just keep them on it, even though their EF has resolved, right? Because you're worried about not just the heart failure or the pump failure, but also arrhythmic events. And although we know that yes, larger scar burden equals larger arrhythmic risk, even small scar burdens can be associated with an increased arrhythmic risk compared to no scar. Yep. All right, thank you.